Welcome everyone to the EKG case for the week of May 12th, 2014. This is Amal Mattu at University of Maryland. Just a couple of reminders before we get started. Once again, don't forget, for those of you that are not logging in on our website, if you're logging in on YouTube, that's great. But if you go to our website, www.ekg.umem.org, instead of looking at these on YouTube, you can actually get written summaries that one of our cardiology fellows, Dr. Ali Farzad, has been working painstakingly to put on the website. And I hate the thought that so many people are looking at these videos and not seeing his handiwork. So check out the videos on this website. It's completely open access, so no harm in just going right to the website and getting some of the summaries that he's been posting there. Also, if you follow me on Twitter, you can get tweets, I guess, every Monday when these get posted. And there's my email again if there's any questions. People still try to find my email through the internet and through our university website, and I don't usually check that email. If you want to get in touch with me or any questions or comments, please just send me an email at amalmatu@comcast.net. Another reminder, about 2 weeks ago, our residency held its annual EKG competition, or ECG competition, April 30th, 2014, and it was a tough competition. Every year I try to put some really tough cases together for the residents, and we have an annual winner, and I haven't announced the winner of this year's competition, but if you're interested in checking out the competition, the test that our residents took, you can get a copy of the test at this website, lectures.umem.org/2014 ECG competition. You do not need to put www first. Just go right to this website, put that address in your browser. You'll be able to download the PDF for the full set of 20 questions that the residents went through, and you have a chance to test your own skills, see how good you are. The learning and the I guess curriculum that the residents get to help them get through this test, or at least upon which this test was based, is this very same curriculum that's on the eMed Home Advanced EKG workshop that we did. And if you go to www.emedhome.com and you're interested in getting that 7 to 8 hour EKG course, which again is what the residents learned during the course of their residency to take that competition, you can go to www.emedhome.com and subscribe to that premier ECG workshop. I didn't come up with that name. I just call it the Advanced ECG Workshop. But anyway, if you want to learn a lot more about electrocardiography, tough EKG, emergency department cases, check out that website. Okay, onto the case for this week. This is a fantastic case that was sent by a fourth-year resident at the University of Toronto Emergency Medicine Program, Dr. Maxim Ben Yaakov, who has sent me a handful of interesting cases over the past couple of years. And Max, as he likes to be called, was the chief resident last year, and this year is continuing his training. This was a case that he and his colleagues were taking care of. Excuse me. It was a 40-something-year-old male who was out on the street up there in the Toronto area having a seizure. There was no other information, and so they called him John Doe. We've actually had a bunch of his brothers and sisters in our emergency department. John Doe. It's kind of interesting. I figure up in Ontario, they would probably have a more French-sounding name for unknown patients who come in rather than John Doe, which also led me to wonder if in other countries they use the same name, John Doe, or if there's some other typical name that's used for unknown patients in other countries. If there's some typical name in your country, send me an email. I'm kind of curious to find out what these unknown patients are named in different countries when they show up in the emergency department. Okay, I digress. Let's get back to the EKGs here. So this 40-year-old guy is out there seizing on the street. And seizures, by the way, are on and off. I guess he's had a couple of seizures by the time he comes in. I doubt that he's regained level of consciousness. So technically, you could call this status epilepticus, and just like any good emergency physician, they started right down the ABCs. Oh, a couple other important points. You get vital signs on this guy. He's tachycardic. He's hypertensive. He's got a temperature of 40.1, which may not be all that uncommon when somebody's had repetitive or recurrent seizures. That's a pretty good temperature, though. We see a lot of seizure patients that have low-grade temperatures. This is a little bit higher than I'm comfortable with. But anyway, they went right on down the ABCs. Airway, breath sounds, circulation. D for disability. I also like to think of D for dextrose or D stick. You want to check their finger stick. And E for EKG. Wait. I think E is supposed to be expose the patient or exposure. And the whole reason you're exposing the patient is so that you can do the EKG. At least that's the way I think of it. Why would you need an EKG for seizures? Well, I think getting an EKG is important for seizures. One of the things that you're always going to be looking for is evidence of the prolonged QT, which we've talked about. Prolonged QT can cause torsade, which can mimic seizures, and there might be other things that the EKG can reveal. A lot of different causes of seizures are related to hypoxia, and EKGs can give you information about that. It can also give you information about overdoses and so on. So anyway, we got a 12-lead EKG, or not we, but Max got a 12-lead EKG, and we can look at this 12-lead EKG. Here it is. It's a fairly regular, wide complex tachycardia. The rate looks like it's in about the 150s. It kind of looks like ventricular tachycardia. But whenever you see a 12-lead EKG, you want to look in all of the leads, right? Look in all of the leads. If you got rhythm strips, there's 2 rhythm strips here. So I'm going to look in all 12 of these plus these. So I've got 14 different leads or strips that I can look at. And when you look carefully at the rhythm, especially out in, say, V3 and V4, and we'll actually blow those up a little bit, you might actually appreciate that there's little deflections right at the kind of on the latter half of the T wave. There's those in V3 and in V4 you see them pretty good. And one of the reasons that you want to look in all of the leads is because sometimes P waves, for whatever reason, seem to be more obvious in just some leads than in others. We've talked before about how sometimes just V1 and V2 are your key money leads when it comes to finding P waves. In this particular case, I think it's V3 and V4 that show you P waves. So this is actually sinus tachycardia, all right? Sinus tachycardia with the heart rate in the 150s. What are some of the other things? Well, just in terms of talking about what we observe, we clearly observe that the QRS complexes are wide. We see that the S wave is really down in lead 1. So this is a rightward axis. There might be a somewhat prolonged QT in there. There might be some ST segment depressions out in here. So just in terms of listing the different things that we see, sinus tachycardia rate of approximately 150. There's a rightward axis, a wide QRS. There's some ST depressions in the precordial leads. I didn't put it up here, but you can probably make an argument here that there's a long QT as well. And so, as we've said before, when you identify any abnormalities, you need to stop for a second and think about the differentials for those abnormalities. So first of all, let's briefly talk about the differential for a rightward axis. What are the things that give you a rightward axis? Well, this is probably not totally comprehensive, but these are the key things I'd like to think about. And if you get in the habit of going through these differentials over and over and over, then they will stick. This may seem like a long list. It's not. You will start to remember these things if you practice them. All right, so right ventricular hypertrophy, left posterior fascicular block, lateral MI, ventricular ectopy, hyperkalemia, the syphilis of electrocardiography, or the great imitator. You want to make sure hyper-K is there on every list. Sodium channel blocker toxicity, acute PE, and misplaced leads. So let's go through these one at a time. Well, right ventricular hypertrophy, I suppose we'll keep on the list. We're not going to automatically exclude it. I'm not sure that there's I'd have to actually look up what the criteria is to define right ventricular hypertrophy in the presence of a right bundle branch block. They are oftentimes, they usually do not coexist together, but I don't know that criteria off the top of my head. If there is criteria, after I finish this, I'll look it up. But I'm just going to keep it on the list for now. I'm going to cross left posterior fascicular block off the list. That's usually associated with the more narrow QRS. Lateral MI, I don't think that we saw Q waves. No, there's no Q waves out in leads 1 or V5, V6. So tell you what, let's cross lateral MI off the list. We've already established that this is sinus tachycardia, not VTach. So we're going to cross that off the list. Hyperkalemia, of course, has to stay on the list. It's possible, but you know what? Let's go back for a second. I don't see really peaked T waves here, so we'll keep it on the list anyway, but I'm going to put it a little further down. Uh, Sodium channel blocker toxicity is a possibility. That stays on the list. Acute PE, the classic S1, Q3, T3, that's probably unlikely. And also, certainly a person who's found down seizing, we'll probably get rid of that. And then misplaced leads. I don't think there's anything here saying or shouting out that the leads are misplaced. So, tell you what, we'll cross that off the list. So, right off the bat, we've already narrowed the differential down to a couple possibilities. I'm going to put a question mark here. We've got hyper-K on the list. We've got sodium channel blocker toxicity on the list. So, we've knocked the differential down to just a few things. We're going to go forward and look at the differential for a wide QRS complexes. All right. What are the things that give you wide QRS complexes? Well, bundle branch block does it, and we will keep this on the list because of right bundle. We don't see any pacer spikes, so we'll get rid of that. We don't see short PR with delta waves, we'll get rid of that. We don't see VTach, we've already established that this is sinus tachycardia. Metabolic, well, there's that hyperkalemia. Acidosis can give you a wide QRS, so we'll keep that on the list. There's that sodium channel blocker toxicity. It's on the list once again. And when you don't see any of these things, what we'll often do is if we don't have a good reason for a wide QRS, we just tend to call it non-specific interventricular conduction delay. And that's kind of a junk term that includes LVH and a bunch of other things. So take a look. We've narrowed the differential down already. We've got right bundle, which is non-specific, and these two things are really jumping out at you. Now you start throwing in some clinical information. The patient was found down, intermittently seizing. This sounds an awful lot like some type of metabolic problem or an overdose. Throw in the fact that the patient was febrile. Okay, hyperkalemia and acidosis are usually not febrile conditions. The patient was extremely hypertensive, probably not hyper-K or acidosis, and so on. So things are really starting to look like sodium channel blocker toxicity. And you get to this differential, you get to this diagnosis just by knowing some differentials on 12-lead EKG and then throwing in just a little bit of clinical information. So very, very simple. All right, so let's talk a bit more about sodium channel blocker toxicity. This is a boards type of question for those of you that might be studying for board exams. What are the typical EKG findings for sodium channel blocker toxicity? Tachycardia, typically sinus tachycardia. Rightward axis, tall R wave in AVR. There is the tall R wave in lead AVR. Okay, wide QRS, we've got that, and also a prolonged QTC. So this EKG pretty much has all of the classic findings of sodium channel blocker toxicity. And what are the different types of sodium channel blockers? This is a very generic term. Well, there's tricyclics, there's just general anticholinergics. There's a ton of sodium channel blocker medications. But what's unusual about this particular sodium channel blocker is that the patient had seizures. Well, tricyclics can do that. Anticholinergics can do that. Fevers, well, anticholinergics might be able to cause some fevers. Tricyclics typically don't. And by the way, before people challenge me on this, I actually contacted Dr. Bob Hoffman, who's become a good friend over the years. We've worked together at different conferences. Bob Hoffman is the director of the New York City Poison Center at Bellevue Hospital and is probably one of the smartest people in the galaxy, one of the incredibly smart people who is actually understandable when he talks. Anyway, Bob gave some pearls, sent me some pearls by email regarding this particular case that I could go into regarding the tox section. And one of the things that he mentioned that I didn't know or hadn't really thought about before is that tricyclics typically do not cause fevers. Some anticholinergics might, but tricyclics not necessarily. And the other interesting thing is that tricyclics do not typically produce hypertension, On the other hand, hypertension, fevers, seizures, those tend to be more common actually with sympathomimetics, this little triad right here. So now you start thinking, again, we're getting away from the EKGs, but that's okay. You start thinking, what are the sympathomimetics? What sympathomimetics are there that also have sodium channel blocking effects? Well, the answer becomes very simple. It's cocaine, right? Cocaine, a lot of people don't realize it, but cocaine is a sodium channel blocker. It has type 1A and 1C effects, and it will produce the very same typical EKG findings that we've all learned for the classic tricyclic sodium channel blockers. Cocaine will produce the YQRS, the right bundleish formation, the rightward axis, the tall R wave in AVR, the slightly prolonged QTC. Cocaine does all of those things, plus it does a couple of things that the tricyclics don't. It produces profound hypertension, and it can also produce significant fevers. And so this is a classic cocaine overdose, and that's exactly what this patient had. The patient was had overdosed on cocaine, and Max was way on top of this. They started cooling the patient. They got high doses of benzodiazepines on board, gave some bicarb. After, I think, just a short time in the emergency department, the heart rate had decreased down to 118. The QRS has narrowed maybe just a little bit, and the QTC maybe a little bit better. The key thing I'm looking at, though, is the heart rate's gone down, and then they continue the cooling, big time benzos. And again, if you didn't sort through this and come up with the diagnosis of cocaine, you might not have been as aggressive about benzos. But realizing this cocaine, you're going heavy on the benzos, heavy on the bicarb, just like you would with any other sodium channel blockers. And after about a day of treatment, take a look. EKG is pretty much normalized. You've got a narrow QRS. There's no tall R wave in AVR, just a small R wave in AVR. And there's no rightward axis anymore. There's a nice QTC. And we mentioned already the QRS is nice and narrow. So problem solved. Benzos. You want to cool these patients because fevers are a really bad prognostic factor in these type of patients. And then you go with the bicarb also, since these are sodium channel blockers. All right, so quick take-home points. All right, know the differentials for rightward axis and YQRS. And whenever you read an EKG and you see a rightward axis, just practice going through that differential. Whenever you see a YQRS, practice going through that differential. They will become second nature to you, I promise. You just got to keep going through it over and over. All right, boards type of question. What are the classic EKG findings for sodium channel blockers? Tachycardia, rightward axis, tall R wave in AVR, wide QRS, and long QTC. And then cocaine versus tricyclics. Well, cocaine typically gives you high fevers. Tricyclics do not typically give you high fevers. Cocaine also typically gives you hypertension. Tricyclics in bad toxic cases are more likely to make you actually a little hypotensive. So I want to thank Dr. Hoffman for sharing his wisdom with a couple of these last pearls that I've put up there. And I hope this case is helpful. It's a fun case, and congrats to Max for managing this patient so well, and thanks once again for sharing a really fun case. So the patient turned out well, and you can't ask for anything more than that. You get to learn something and take good care of a patient. All right, so I look forward to talking to everyone next week. Until then, take care.